Good afternoon, everyone.
Thanks for being here on another Medicaid Monday.
That's right. I'm Aaron Connor. He's Frank Hemming. Displays the other way on your screen, but
We know who we are.
that's right. So thanks for being here. Frank does this every month.
Just about.
Some months, but it's not just me and Frank, or just Lou, me and Frank, or however you want to put it. There's a lot of us here, so we practice in the areas of estate planning, elder law, state and trust litigation, special needs planning, and of course Medicaid and things related to those areas. So if you have a need, we are here to help. And Frank, why don't you take this?
So we're going to talk about numbers because we always start with numbers. Probably not a numbers focused presentation today. I think this is going to be a lot more of discussion, information sharing, and probably some Q&A at the end. We're going to do some numbers. We're going to talk about the big, beautiful bill and Medicaid cuts that now I think have had some time to settle, and kind of the things that we've been seeing from people that get paid to analyze such things. We're going to talk about some changes in getting eligible for home care. We've been kind of forecasting this for some time. So some of these changes that we were worried about for since back in 2020, believe it or not, are actually coming to roost very, very, very quickly. We're going to talk a little bit about the look back, even though that's not quite here yet. So spoiler alert for later in the program, the look back isn't here yet, but we're going to tell you what we've seen about that and what we're forecasting for that. And then we've got some few quick updates on CDPAP and the rollover to PPL and the single fiscal intermediary for the state. So that's probably going to be enough of what we're going to have for our half hour today, if that didn't sound like too much.
Sure. Well, it did sound like a big bite, but we'll see how we do. So basic rules, right? Need to know your basic rules. You got to divide your world in between assets and income.
Yep.
And these haven't changed.
I'm going to say the nice thing is, again, I don't have to learn new numbers until next year. They haven't changed. We've gone through these quite a few times now. But again, if this is your first time with us, welcome. Thank you for being here. But for income, if you're a single person trying to get on home care, your income allowance is $1,820 per month. A couple, it's up to $2,453 a month. And then on the right-hand side, we have our asset limits. So again, that's your resources or the things that you own that are not otherwise exempt. So for a single person, it's $32,396. For a couple, it's $43,781. And then those bottom numbers are just kind of good to know if they exist, and to have a general knowledge about what they are. If you're a community spouse, meaning that your spouse is on Medicaid, but you are not, you're in the community, your income allowance is just shy of $4,000, so $3,948. Your resource allowance or your asset level, if you're a community spouse, is that weird calculation between $74,820 and $157,920. And then that bottom number, they never changed that one. That's your institutionalized spouse income allowance of $50 per month. Same thing since 1965. Hasn't changed. Know that one pretty well at this point.
So one of the things we're talking about is how Medicaid will be impacted funding-wise, right? Because Medicaid is a federal program with state overlays. It's kind of not unique, but unusual in that way. Usually a program is controlled by one or the other, not both.
No, and it's the way I always kind of think of it is, if it wasn't confusing enough, right? Let's add more layers of complexity where you've got the state, you've got the feds, you've got them working together or not working together, however you want to look at that. And that's where your huge pot of Medicaid funds comes from, both state and federal funds.
Right. So based on legitimate projections, this is the way the cuts look to play out. So increasingly getting deeper. Now, we all know that things may change between now and 2030 or 2032. So we want to focus on the immediate impact because we can at least be pretty well assured that that's going to happen.
Yeah, and I don't know about your thought, Aaron, but I think the first one that I thought of when I saw that projection in that graph was not that any of the numbers are good, but it seems like it just staggeringly gets very, very bad the longer you get into that period of that 10-year projection. Right. So not that the projected, what was it, 17 billion next year. Not that that's a good number, but that's
the best number, though.
I'd say, but considering that's a heck of a lot better than the 165 billion projected cut 9 years later, right? Back in 2034.
Right.
So I don't think it's for us to say what's going to happen, right? At the end of the day, these are all projections. I actually did do quite a bit of reading about this last night just to make sure that we were current with some of the thoughts behind this. But you know, at the end of the day, there are projections. So I guess the good news is it may be better than that. The bad news is it may be worse than that.
That's right.
They're projections.
So on average, this is what New York is looking to lose per year. And we're going to get into what the cuts are, but it's going to affect a huge swath of the population.
Yeah, I mean, 1.5 million people without insurance. That's a big number, right?
Yes.
I mean, it's essentially doubling the amount of the state's uninsured population currently. So, you know, just generally speaking, I don't think anyone would kind of look down from a large or from a wide scale view and think that everything is great right now. Well, imagine if you take everything that we're kind of seeing, just the climate that we're seeing it in, and then we're going to tell you we're going to double the amount of people that don't have insurance, and then we're going to have to figure out how to care for all these people, keep people safe, and do all the regular things that our healthcare system is already trying to do for a lot more people.
Right. So a lot of these losses are going to be sustained by hospitals, at least that's what we're seeing right now. Okay. A lot of jobs at risk there, but that's not really our focus. All right. So we want to keep it kind of where it's going to impact our people. Right. So a lot of the cuts are to what would be Obamacare, Medicaid,
Yes.
right, as a health insurance program.
Yeah.
Now, we see lots of people on this, even walk through the door, whether they're older people, whether they're younger people with special needs, or lots of other areas, right? So that's a problem. But for us, we need to focus on the long-term care aspects, right, and effects. And we can't know for certain what they're going to be because this year's budget is really essentially baked, right? And while $45 million is not a small amount of money, in the scheme of the cuts, that's all that's being lost this year.
Yeah,
right.
I mean, if you said let's sign up for 45 million going forward, and that would just be what we have to deal with,
Right.
I think everyone would take that, right?
Right.
Just seeing the numbers that we're seeing.
So we won't really see a big impact, at least till next year, right? Because there's going to be a shortfall, and as that shortfall increases, what is the state going to do, right? That means it's going to essentially have to make it more difficult for people to access.
And again, just going off what's been shared and discussed, you know, again by the Fiscal Policy Institute that we have on the slide and some of the other news stories that we were tracking when we were putting this presentation together. As Aaron said, a lot of the projected cuts are going to Obamacare, Medicaid, which again are your population between 18 and 64, rather than using it more for health insurance more than anything else. Not that there aren't other groups included, but those are the biggest group of people. And generally speaking, one of the reasons why they're projecting these cuts is because there is this work requirement that's being put into place to obtain Obamacare, Medicaid, or you know, Medicaid for Magi people, if you've heard that, MAGI, which is generally based upon your income. That's usually why people are on that type of Medicaid in the first place, is either they don't work or they don't make very much money and they want to get health insurance. So they go to the marketplace and they get health insurance that way. But if they start requiring that people work to obtain health insurance, well, that's kind of the reason why a lot of people are on such program, because they either can't work, don't work, or whatever.
Exactly. So what's likely to happen? Well, some things have already been put into place, just not utilized, right? And we will talk about some of those home care rollbacks. But ultimately, nursing home Medicaid isn't going to go anywhere.
Yeah, I mean,
because all of the cuts really have pushed towards that.
Yeah, I think the bigger issue, and again, this is just my general understanding of it, but the kind of the worrisome thing when I think of nursing home Medicaid with the cuts, given what I've read so far, is kind of that middle bullet on the slide now, and that's that ripple effect.
Right.
Because hospitals are going to be hit with this, I think, more than just about any other provider scenario or segment as we've been seeing. So if hospitals start closing or having to even make more difficult budgetary decisions, ultimately what that's going to mean is people are going to get sicker, or there's going to be less people to take care of sick people, less beds to put sick people in. And we already have, I think, generally a statewide issue with the number of Medicaid beds available in the state. there are only so many beds. There's no new nursing home construction unless something has cropped up very, very recently. So when you already kind of know the end game of what you're dealing with, and now you're seeing just more pressure being put on that system from outside forces where you haven't seen it yet, what's the only logical result from that is everything's going to get tightened and everything's just going to become harder.
I think ultimately you'll probably see less rehab as well.
They might just need the beds.
Right.
Right. For
So-
long-term beds, right? Less rehabilitation time and more long-term beds. It's entirely possible. I mean, it makes
And
logical sense. Too.
Obviously, New York can decide as a state that they want to support these costs on its own.
Right.
Right. But I'm not sure fiscally how that would work either
Let's say that's
without significant, tax issues.
yeah,
So-
that's going to bring new issues to the plate, right? Because then
Right.
if New York wants to shoulder more of the burden, they're probably more than capable of making that decision. But then the question becomes, where did the funds come from? Because
At the expense
the dollars have to come from somewhere.
Exactly.
So
One thing we can tell you that is already being done to limit access, right? Is changing ADLs.
yeah, so I mean, I don't want to say one of the good things about the home care Medicaid is that there was a relatively lenient medical standard, but it's getting harder, and it starts as of September 1st, so in just a few weeks. So if you're new coming on to Medicaid, meaning you want to get personal care services, consumer directed personal assistance program services, MLTC services, generally home care what we generally just call community Medicaid home care services, and you haven't otherwise been in the program, well, when you go through your assessments, they're going to look at you medically, and you're going to need assistance with at least 3 activities of daily living, where previously it had been 2. And this is the kind of thing where I think it's going to be difficult to forecast the ultimate scope of this change.
Sure.
Because I can say without hesitation, a lot of our clients, when they come through the door, our prospective clients, the difference between 2 ADLs and 3 ADLs is probably not that big of a jump for them.
Yeah, most people who come to us have tried to weather the storm to some extent on their own,
Yes.
right? Either with a spouse or children or whomever.
Yes.
So it's not generally that people come to us and they have a 1 ADL problem, right?
Rarely, I would say.
There are very few clients or potential clients that have been in borderline cases. There have been some,
Yes.
but it's not, by far not the rule. So I don't know how dramatic or undramatic it's going to be quite yet.
I mean, to look at kind of the other side of the spectrum, if you have somebody who needs essentially 24-hour care,
Right.
They're going to need 24-hour care, and they would qualify for 2 ADL assistance or 3 ADL assistance. And that doesn't really make a drop in the bucket for qualification purposes. The bigger, long-standing impact is, we've been, as attorneys, we've been counseling everyone for as long as we possibly can, whether it's through webinars like this, the radio, information blasts, sitting with us in person. The best plan for home care is to get out in front of it early.
Right.
This will make that harder because you won't be able to get out in front of it until your loved one is more in need of care than before.
Right.
So even if you want to be proactive, you still can be, but you've got to kind of get through where they might need some assistance, but it isn't a lot.
Right. And ADLs, generally speaking, there's 6 ADLs, right? Showering, toileting, transferring, food preparation. What am I forgetting? Dressing.
Yeah. And meal prep. Or medication management.
Medication.
There's also IADLs as well. So
Right.
sometimes the line gets blurred depending on the testing tool.
But just so people understand what we're talking.
Yes. And then they didn't just make a change to looking at people that just need physical assistance. There was also that carve in that if you had Alzheimer's disease or a dementia diagnosis that you needed supervisory assistance with 1 ADL, well, that's also being increased now to 2. So again, how widespread this will be, I think only time will tell. I don't think I can think of many people when they brought in their loved one or they brought their case in, if they were dealing with this kind of case, like where there was, Alzheimer's, dementia, cognitive impairment, and only 1 ADL, where now it would be two would now, where they
Yeah,
only needed
trying
one
to
and now
think
they
of
would
it.
need two. I mean, I can't say it's never happened. I don't really know the extent of how widespread this will
The first one is always medication management, I feel like.
Yeah.
But often meal prep is and toileting are not very far behind that usually, or showering, right? There are a lot of people that are mentally or somewhat physically well that would have trouble transferring, would have trouble showering on their own without assistance. So.
And we wanted to make it as clear as we could of like, again, who does this apply to? So again, it's people seeking their initial assessment for personal care services, CDPAP services, enrollment in MLTC plans. Also could apply to reassessments, but we're going to talk a little bit about that in the next slide about, kind of what we're forecasting for this, where hopefully grandfathering will still be available but there's kind of like a little nuance in there. So why don't we go to the next slide and I can kind of like weigh in on that.
Yeah, absolutely.
One of the biggest questions that we were in the dark about all of this was like, who was this really going to start affecting with these ADL changes? So the biggest way to, I think, make this as clear as we can is just to kind of go through like we have on the slide. So if you've been assessed by the independent assessor's office between September 1 of last year and September 1 in a few weeks, and then you have to enroll in an MLTC plan or to personal care, CDPAP, right? There's general home care services. You still would have 1 year of that assessment to then enroll. Right. And you would still be grandfathered in under the 2 ADL requirement rather than the 3. So really the take home point is get assessed if possible by NIA before September 1, 2025. Again, that's in like 3-ish weeks.
Yes.
If you can do that, you don't have to enroll right away. You don't have to be enrolled before September 1, but you have to be assessed before September 1.
Well, let's be honest too, just the fact that you have to do anything more while on a program is a way of knocking people off the program, right?
Right. Yes.
Because many people receiving this care could not do this on their own, for sure, right? And there are many people who don't necessarily have an advocate to do it for them.
Right. So the big thing here is that you have to continue, and then we're, again, just like the slide is saying, if you're continuously enrolled in MLTC, you get what's called legacy status, where you're grandfathered in, and then you don't have to meet these requirements. Now, that's like the caveat, is that you have to be continuously enrolled in MLTC. So one of the things that everyone, again, was up in arms about with the PPL transition and everything else was people weren't doing all their paperwork like required, or now that research are now a thing where they weren't for a few years because of COVID. There's just a lot more kind of bumps in the road where people can be disenrolled from their managed long-term care company, even if it's only for a month or two, get their services reactivated, and then ultimately go back.
But you're not a legacy at that point.
Right, and that's exactly the point, right? So even if you lose it, even if it's just for a month or two, even if you're otherwise Medicaid qualified, but you fell off your plan, if you have to kind of re-enroll and pretend to like start out from scratch, if you will, well, now your legacy status was lost when you were disenrolled, and now you're going to go under the new rules, meaning the 3 ADL requirement, or the supervisory assistance with at least 2 if you have a Alzheimer's or dementia diagnosis. So again, more potential hurdles where the system might just see a slow drop off of people, even if they're currently on, just because they're putting that increased pressure that you cannot lose your benefit without the ability then to be reassessed and potentially then denied, because now you're not sick enough where before you were.
Right. So today we live in a world where there's no look back for Medicaid home.
I just said it to some prospective clients this morning that as we sit here together, still no look back.
But dun, dun, dun.
Right. Kind of gave it away, right? Or at least what we're thinking, right? So there have been several reasons why the look back couldn't occur. Jokingly, I think I've said in the past few webinars when we've been talking about the CDPAP transition, they already have enough going on. They don't need to throw something else on their plate, but that seems to have calmed in comparison to what it looked like several months ago. Not to say that it's all good and well and everything's going smoothly. It's just, it's not quite on the front burner quite like it was a few months ago. So in order for them to institute the look back, for one, the Center for Medicaid and Medicare Services has to approve New York's spending of the what were called American Rescue Plan funds, which were just funds that were allocated to the state during the COVID emergency. So for a long time, we weren't sure if that had actually happened or not. So based on our last review of all the available information online, it looks like that letter was issued by CMS to New York sometime in July or right around July. It wasn't, I think, immediately posted where I think a lot of people were expecting it to be, but we have been informed that that has occurred. So that has now been taken care of. Second thing is then, again, Center for Medicaid and Medicare Services has to approve a state plan amendment of the Medicaid plan. I believe that's in process. A lot of that was very dense and not something that I look a lot into, but I generally think that that has occurred, that they've at least asked. And they also have to then approve the Department of Health's request to amend one of the waivers that, again, go to kind of the overall structure of the Medicaid program that would allow a look back to then be implemented. And that is pending, right? I did see that online. There's a very quick way of seeing that status, and it was listed as pending as of last night when I looked. So again, it seems like it's not done, but they've at least asked for it. And then the last piece is that then once those other kind of pieces fall into the puzzle, then the Department of Health then has to issue its directives and directions and things like policies to the local departments of social services and the HRA office in New York City of how a local Medicaid agency would even process a case with a look back period if it's a home care case, because all through this time there's been no look back for home care.
And generally there's 90 days or more before that type of thing.
Yeah.
Once that's issued.
Yeah.
Because there's going to be a lot of phone calls from counties.
Yes.
There's going to have to be guidance about how to treat transfers.
Yes.
And pool trusts.
Yeah, and calculation of the penalty period. I mean, not that we're anticipating it's going to be different, but I think there's just a lot of kind of unknowns, right? We've always
have people to do it.
Right. And that's, I was saying, more than anything, again, just speaking logistically, I still don't think that my general thought, if asked, would be Medicaid offices are being well staffed. I think they have certainly gotten slightly better in the last few months, I would say. We've certainly been seeing some new workers emailing us about our cases from counties where we have our relationships. So it seems like they've been staffing those offices better than they were a few months ago. But you're essentially taking a worker's amount of work on a home care case from current financials or a month or so's financials, and then increasing it to 30 months of financials. Right. And it's not like there's usually one or two Medicaid applications coming through at a given time. So, I mean, there's
going to be litigation too.
Right. I mean, and that's all the unforeseen. So it's only a matter of time to see kind of the ultimate effects of some of that as to what it will do to the county offices and things. So whether a look back will be coming later this year or whether it might even take into early next year, it's not really for us to say. But it seems like all the machinery is kind of working in the right way to eventually institute all of that. So just goes more and more to say, if you have somebody who needs to get on the programs, it's going to be better, easier to do it before they start instituting all of these changes. If you're not already pretty much in process, that 380L change is going to be one that you have to deal with going forward. But you can still do the planning, the qualification, and the Medicaid ultimate approval, even with the higher medical standard, with no look back until they change it.
Right. So some of you may be aware, or all of you, that we went to a single fiscal intermediary for the CDPAP program, and that went less than swimming. Okay.
That's probably the nicest way anyone's put that.
Yeah. Maybe trying to swim on dry land. It's kind of how it went. I'm not exactly sure. But there was a settlement in a lawsuit. What a lot of this means, really kind of hard to know, right?
Yeah, I mean,
it was a pretty nebulous results.
Yeah, I mean, I think it was great that a good result for consumers was achieved because clearly people were affected by all of the things that were happening, whether it was misinformation, disinformation, disenrollments, home care hours not having an aid for, people not getting paid, just the overall confusion, the anxiety that came all with. And a lot of the proactive measures that were being taken due to this were trying to avoid all that, trying to have more written notices issued, better training people to direct consumers, to have their issues dealt with, their questions answered, get more concrete results for people that rather than just keep calling the same number, getting hung up on for days. and making sure that your aides got paid.
Those seem like all things that should have been worked out in the first instance.
But on the other hand, like it's kind of Band-Aid measures to go forward. It doesn't fix any of the issues for all the people that were affected previously. So, you know, whether that was ever going to be on the table to give a remedy to those who had already been affected, right? That was probably unlikely to occur anyway, just because of the type of nature of the issues and everything that happened. But to say that no good will come of this, I don't think that's accurate. Some good will come of it. It's probably at the end of the day, everyone's probably going to be a little upset about it. And then PPL going through a leadership change. Their president resigned. She's not out of there yet. I think she has until the fall, so maybe within the next month or so. But she'll be stepping down. A new CEO will go in, and then there is a joint Senate legislative hearing that's to occur in just about let's look, 10 days, give or take, where several stakeholders and different types of people are going to be able to go before a joint Senate group to talk about kind of what's been going on, and they can either continue making changes to it. They are going to hear what has to be said and kind of take best steps going forward. I believe I think that was supposed to occur earlier, but then it got delayed, and now it's on the books for the 21st. I don't think you can just stream that. I think you have to be invited to see that. But I could be wrong about that. So obviously, if I'm wrong, somebody can throw that in the chat.
So as we say all the time, these things don't get better. So it's better off to get out in front of it and take advantage of things while they're available to you. I don't know about you, Frank, but I don't know that I could ever jump that high as the guy in the picture, but you don't want to have to be jumping through these hoops. So get out in front of it, make a consultation, and come talk to us. Now that the next Medicaid Monday summer will be officially over.
Yeah, that's sad.
Yes, yes. But it'll be about how to maximize your Medicaid home care, and that includes paying for as little out of pocket, getting it as quickly as possible, and getting as much as possible. So follow the link that you registered for today.